The self-named Society for Evidence-Based Gender Medicine is holding their annual meeting in Berlin this year, centering on trans youth. The society has a credible name, Evidence-Based Gender Medicine, but how credible are they really, and what is their reputation? Who are the speakers? Are they doctors who actually treat trans people? Are they clinicians with hands-on experience supporting young transgender people and their families? Are they trans people themselves, bringing their lived experience into the room? When you see a panel with a title like Gaps in the Research or Senior Clinicians Reflect on Treatment, I ask myself this: who is actually on that panel, and what are their preconceived thoughts about trans healthcare? Are they open to evidence, or are they already opposed to care? How many people have they personally treated, supported, or cared for? And how many genuine experts in gender-affirming medicine are there? Perhaps the most important question of all is how many trans people are on that panel sharing their lived experience. The SEGM were extensively reviewed by two researchers in 2023 in a very comprehensive investigative report, and they detailed the Society's promotion of medical disinformation on gender-affirming care and the Society's strategic efforts to shape both public opinion and professional guidelines against transgender healthcare. I worry that this conference is going to give politicians new sound bites to justify restricting healthcare, to provide lobbyists with papers that they can wave around to block rights, to fuel parents' fears instead of answering their questions with compassion, and to silence the voices of trans people, replacing them with transphobia dressed up as evidence. The harm caused by misinformation is very real, and these ideas will ripple outwards into laws, into policies, into homes and into families. And it will be today's trans young people who will suffer the most. Let that sink in. Real harm, real suffering, real pain. I've taken their agenda and I'm going to ask myself the question: what does the real evidence say? And then ask the question that I always ask: how can we help transgender young people live their best lives? Thank you to Jack Turban for compiling all the best research to help inform us. Suffice to say that he is an expert in the care of transgender children, and we should be listening to the experts. I've summarised his review in a document linked in the bio. It's a good read. So who should we listen to? Well, I propose that we listen to the real experts, those who work with transgender patients as their routine work, those who have published evidence-based guidance and research studies, those who have lived in a family where trans people exist in real life. The World Professional Association for Transgender Health, or WPATH, and the Endocrine Society are perhaps the leading international bodies setting standards of care for trans people. They, together with the American Academy of Pediatrics, have been crystal clear. Supporting and affirming trans youth is the best way to safeguard their health and their well-being. All of these organisations recognise social transition, puberty blockers, hormones and surgery as legitimate life-saving care. So let me put this to you. If major medical organisations in the world support gender-affirming care, and a tiny fringe group like SEGM does not, who should we trust? What is the history of paediatric gender medicine? Well, fortunately, we're talking about decades of learning, research and progress, not some new experimental fad. In the mid-20th century, being trans was framed as a psychological problem, and children and adolescents who expressed gender dysphoria were often subjected to conversion-style approaches. Attempts were made to talk them out of it or force them to conform to their birth-assigned role. Children were made to feel ashamed if their gender identity didn't match the one they were told to be, and many, many adults today look back in deep pain at the harm that caused them. By the 1990s, things began to shift, and in the Netherlands, researchers and clinicians at the Amsterdam Gender Clinic developed what became known as the Dutch Protocol. This was the first structured approach to care for trans adolescents, supporting social transition, prescribing puberty blockers when puberty starts, and then, when appropriate, using hormones in later adolescence. The premise was a very simple one. Instead of forcing teenagers to live in their birth-assigned sex, we could allow them to live as male or female or somewhere in between. We could also use medicine to stop pubertal development and to prevent their bodies developing in ways that were completely opposite to the gender that they identified with. And then we could even give them the opposite hormone so that they developed secondary sex characteristics that matched their gender. Girls would grow breasts instead of beards, and boys would grow beards instead of breasts. In some ways it seemed so unnatural, but then, there are many girls who are born without functioning ovaries, and there are many boys that are born without functioning testicles, and we're very well used to making sure that their sex hormones are right. In trans youth in the Dutch clinic, the outcomes were remarkable. Young people who received care were healthier, happier, and more stable than those who were denied it. Rates of depression and suicidal thoughts dropped dramatically. These results were published, peer-reviewed, and replicated, and the Dutch protocol became the foundation of modern gender-affirming care for young people. Imagine, if you will, a cohort of happy, smiling trans young people, at peace with their bodies, happy in their social groups, achieving in their education. Since then, the evidence base has only grown. Studies from North America, Europe, and beyond have confirmed the same thing again and again. When trans young people are affirmed, socially and medically, their mental health improves, their risk of suicide decreases, and they are far more likely to thrive into adulthood. What about social transition and why this always makes me smile? I've seen children transform from a withdrawn shell hiding under their bed to a happy and bouncy child running through the school gates. And what did it? A hat or a handbag, a haircut or a hoodie, a him or a her. How can these things mean so much? But they do. Critics will cast doubt. They'll say it's too soon, too risky, or that it will lock a child onto a medical path, but the evidence tells a very different story. Studies show that when children are supported in a social transition, their mental health improves dramatically. Rates of depression and anxiety fall, suicidal thoughts drop. These kids do better at school, they build stronger friendships, and most importantly, they feel safe being themselves. Social transition doesn't mean surgery or medication. There's no permanent step. It's just the freedom to explore who you are in a safe and affirming way. What about the next step, though? What about medication? What about surgery? Well, let's talk about puberty blockers, hormones, and surgeries, because this is where critics lean heavily on the phrase low-quality evidence. They'll say that the studies aren't strong enough. They'll point to the CAS report and repeat the claim that the evidence is weak. They will say that we don't have the kind of double-blind, randomized, controlled trials that are often considered the gold standard in medicine. And why not? Because randomized and double-blind means that neither the patient nor the doctor knows which drug they were given, and that's impossible when you're talking about puberty blockers and hormones, because it will soon be very, very clear whether you were given a puberty blocker or not, and whether you were given testosterone or estrogen. Controlled means that the other group of children are given no treatment, so that we can compare the two, but of course the same applies. Their puberty will develop naturally, and it will be very obvious. So instead, we rely on evidence from long-term cohort studies, clinical follow-ups, and real-world outcomes. And that's perfectly acceptable. It happens all the time without any fuss or emotion. What does the real research say? Well, puberty blockers simply give people time. They're safe and effective and reversible. They stop the development of life-altering, permanent body changes that are at a mismatch with the person's gender identity. Studies show that they reduce stress and they improve functioning. Hormones are shown to improve quality of life, mental health, and social well-being. And what's really important is that the follow-up studies into adulthood show sustained benefits. Surgeries, for those who choose them, have some of the highest satisfaction rates in all of medicine. Regret is exceedingly rare. But didn't the Cass report show a lack of evidence? Well, you'll also hear a lot about the Cass report and the phrase weak evidence. Critics love to hold this up as proof that gender-affirming care shouldn't be offered. The Cass report misused the language of evidence-based medicine to cast doubt where doubt doesn't really exist. And Dr. Hilary Cass and her review team have been widely discredited by international experts for ignoring huge amounts of global data and cherry-picking the research. Sadly, her report is still being quoted by politicians and lobbyists as justification to restrict care. There's a real ethical problem here. What's more harmful, providing treatment with known benefits and manageable risks, or withholding it based on exaggerated uncertainty and watching young people suffer as a result? Ethics in medicine is not just about evidence, it's about outcomes, and the outcome of withholding this care is very clear. It costs lives, young lives. Are there any risks? Critics love to talk about the risks of hormones. They exaggerate the unknowns, making it sound like we're stepping into something dangerous, uncharted territory. But the reality is very different. These blockers and hormones have been prescribed safely for decades, and doctors understand how they affect the body and how to monitor things like blood pressure, cholesterol, bone health. If you have an estrogen hormone profile, you will have the risks of that, whether you have that from your ovaries or from a patch. That's how hormones work. What about autism? Another talking point you'll hear is about the link between autism and being transgender. Critics will try to pathologize it as if an autism diagnosis somehow makes a young person's gender identity less real or less trustworthy or less deserving of care. However, we know that autistic people often know themselves really deeply. They can be less influenced by social expectations and more likely to express who they truly are. Being autistic doesn't make someone's identity less valid. Autistic people deserve exactly the same access to care as anybody else. We also need to consider that some traits of autism overlap with the experiences of trans young people. Difficulties fitting in socially, perhaps, or feeling different from your peers. And this can sometimes look similar, and that overlap can mean that autism is overdiagnosed in trans youth. However, whether a person is autistic or simply has traits that arise from struggling to fit into a hostile world, it should never be used as a barrier to care. Instead of weaponizing autism, we should see it as a call to do better, to provide thoughtful, accessible, affirming support for young people who are autistic and trans, or who simply share some of those traits. Roll out the detransitioners. Another favourite talking point is detransition. Critics will inflate the numbers, suggesting that many, even most trans people, will eventually regret their care. But the evidence tells a very, very different story. The reality is that detransition is rare. Large studies consistently show that the vast majority of people who access gender-affirming treatment are more than satisfied with it. Regret rates for surgeries, for example, are lower than for hip replacements or cosmetic breast surgery. And when detransition does happen, it's not because someone was never really trans. It's usually because of external pressures, stigma from family, discrimination at work, losing community support, or simply not being safe to live openly as themselves. In many cases, those same people later retransition when their circumstances change. So yes, detransition does exist, but it's a tiny minority, and it's far more about how society treats trans people than about regret for the care itself. What about the psychodynamic theories of trauma and personality dysfunction. Another theme that you'll hear repeated is the idea that being trans comes from trauma or from some kind of personality dysfunction. This is rooted in old psychoanalytic myths, the belief that gender identity is a disorder to be explained or analysed or corrected. Gender identity is not a pathology. It's not caused by anything. It's not caused by childhood trauma or poor parenting or some kind of psychological disturbance. It's a natural part of human diversity, recognised across cultures, across history, and across medicine. What does cause harm is the stigma, the rejection and the discrimination that trans people face. That's where the trauma lies, not in being trans, but in being treated as if trans identity is a problem. Your childhood doesn't make you trans, but your childhood can certainly make you scared to be trans. Well, there's always social contagion. You'll hear that being trans is a kind of sociogenic epidemic, that young people are identifying as trans because it's trendy or because they've been influenced by online communities. Sometimes this gets packaged under the label rapid onset gender dysphoria, or ROGD. ROGD is not a medical diagnosis. It's not recognised by any medical body. It comes from a single deeply flawed study that surveyed only parents from anti-trans websites, and it's been rejected outright by every medical organisation that has reviewed it. Yes, of course, young people do talk about gender online, just as they talk about sexuality or mental health or any other part of growing up. That's not contagion. That's kids finding language for what they're already feeling and finding community and other like-minded people. We should applaud it, not fear it. What is autogynephilia? Now let's talk about autogynephilia, a word you'll sometimes hear in these circles. What does it actually mean? Well, in short, it was a theory put forward in the 1980s by a psychologist, Ray Blanchard, who claimed that maybe trans women weren't really women at all, but men who were sexually aroused by the thought of themselves as female. It's a theory that has been very widely discredited. It's been rejected by the World Professional Association for Transgender Health, the American Psychiatric Association, and countless researchers since, because it's based on sexist assumptions, flawed methods, and it simply does not hold up against lived experience or data. However, if we look at how it's used, autogynephilia isn't just an outdated theory, it's become a weapon. It's used to invalidate trans feminine people, to suggest that their identities are nothing more than a fetish or a perversion. So when you hear that word, remember, that's not science, it's not medicine. It's a discredited sexist theory that's done real harm, and it should have no place in serious conversations about healthcare. Can ethics save paediatric care? Notice the framing here. It starts with the assumption that gender care itself is broken, that it's failing young people, and that only some external rescue can justify its existence. But that assumption is false. We don't need to save gender-affirming care. We need to protect it because it already works. Every day there are thousands of young people who are thriving, studying, working, laughing, and living full lives because they were supported to be themselves. The real ethical failure isn't in providing care, it's in withholding it. It's in telling a young person, we're too uncertain to help you, while watching their distress deepen. Ethics doesn't need to save gender-affirming care. Gender-affirming care is what saves lives.